So we'll be going in a slightly different angle for the next talk. Dr. Buchholz is a world leader in urology. He has authored more than 300 articles and book chapters in world-class scientific publications. Trained in Germany, Switzerland, and Australia, he was the Director of Stone Services at the Royal London Hospital and board member of the Stone section of the European Association of Urology. He now works in Dubai. So please welcome Dr. Noor Buchholz, who will be speaking about metabolism and common urological diseases, the prostate and stones.
So that brings us to stones. Did you actually know that stones have something to do with nutrition? Oh, you did. Good. Good. Now, what we do know is that stones have a multifactorial genesis, meaning that there are about 25 to 30 factors that play a role in stone formation. But there are patients who have none of these factors and they have stones, and there are people who have no stones and they have many of these factors. So again, it's all a bit wishy-washy. What we do know is men had more stones than women. Women are fast catching up because they are adopting the bad lifestyle of the men. They're starting smoking, drinking, gambling, whatever, you know. We do know environment plays a role. We have a stone belt around the world, which is mainly the dry, arid countries. We do know that diet certainly plays a role. Meat, fluid, salts play a role. Genetics play a role, and there are many other factors, stress and so on. Now, each of you here in the audience has a 12% chance in your life to develop a stone. Anybody had a stone so far? Or don't? Yeah. See, with the 12%, there must be somebody in the audience who had a stone. Okay. Stone disease is usually regarded as, you know, you take the stone out and then the pain is gone and you forget about it. But that's not true. It's a highly recurrent disease. If you're a first stone former, you have a 30% chance to get another stone in your life. If you are a second stone former or more, that rate goes up to 70%. And if you happen to, yeah, I have a timer here, thanks. And if you have a uric acid stone, then your chance is 100% of recurrence. So the main risk factors are, of course, high calcium, high oxalate, high phosphor, and high uric acid in the urine, and low urinary volume, low citrate, and low magnesium, and I'm coming to that. Now, integrative medicine. Let's start with the metabolic syndrome. I'm speaking a bit faster now. The risk has doubled in metabolic syndrome patients to form a stone. So if you have one trait of, metabolic syndrome has 5 traits, and if you have one trait, your risk is 3.8. If you have 3 traits, it doubles, and if you have 5 traits, it triples the risk to have a stone. And the risk is reciprocal. That means if you have metabolic stone, you have risk to have metabolic syndrome, you risk to have a stone, and if you're a stone former, you risk to have a metabolic syndrome. You do know that calcium oxalate are the most eminent stones with 80%, and uric acid is about 15% of stone formers. And what all these stones have in common is that the determining factor for stone formation, for crystallization, is the pH of the urine, right? This is what is influenced by our diet and lifestyle. So if you have metabolic syndrome and you have stones, treat the metabolic syndrome and you treat the stones. Of course, the stones you already have, those unfortunately we have to take out one way or another, right? But you can prevent further stone formation. You should treat the low urine volume. You should treat a high uric acid in blood and urine. Tell the patients to drink more than 2 liters per day. Reduce animal protein and reduce sodium because both of those lead to acidification in the tubules and in the urine. Now, we do know that in recurrent stone formers, there's a higher level of free radicals and there's a lower level of antioxidants than in non-stone formers. That indicates some oxidative stress in the renal tubules, and that actually leads to cell damage in the renal tubules, which is one of the important factors. We all form crystals, but these crystals are normally washed out, and one of the factors of stone formation is that these crystals can adhere to the injury in the tubules. And when they sit there, other crystals will join them, and then they will form stones eventually. But they will also be incorporated into the papillary, into the intrarenal tissue, and they form what you see here on the picture of a ureteroscopy. You see a renal papilla with these calcification. They're called renal plaques, and they are thought to be the very early stage of stone formation. These are different antioxidants. If you give me another 20 minutes, I go through that slide? No? Okay. He doesn't. Okay. Vitamins. Now, the main players are calcium and oxalate, as I said. 80% of stones are calcium oxalate stones. We call them the bog standard stones. The oxalate is the much more powerful binder of the two. So oxalate will bind the last bit of calcium it can find. So hyperoxaluria is certainly a risk factor in stone formation. And if you have a hyperoxaluric patient, then you reduce, of course, oxalate-rich food, rhubarb, spinach. Who eats a lot of rhubarb? But anyway. You reduce that, and you can give vitamin B6, which lowers actually the urine oxalate. Some people postulate that it may help in calcium oxalate stone formation as well, because there is a theory that uric acid forms a nidus, a crystalline nidus, on which calcium and oxalate then sit and form a stone, right? So to break this initial mechanism, you can give vitamin B6. Just keep in mind, high doses of vitamin B6 are neurotoxic. Vitamin A is good for stones. Vitamin C is not good for stones. I make it short here. We give vitamin C in urinary tract infections because it acidifies the urine. But we do tell our patients, if you don't drink with it, then you don't get infections, but you get stones. So they don't like that. If you have a high oxalate, hyperoxaluria, for example, you can use probiotics. There is a bacteria called Oxalobacter formigenes, and it's part of the human microbiome, and it only eats oxalate. That's the good news. It only eats oxalate. So it is actually reducing the oxalate content in the gut, so less oxalate gets into the kidney, and I told you oxalate is the much more powerful binder. So if you have a lower oxalate, your chance goes quite down to form a calcium oxalate stone. Calcium is actually needed. I don't know how many of you are old enough to remember that doctors told their patients, don't have any dairy products if you have kidney stones. Right? This is out. Because oxalate is the more powerful binder, you need some calcium to bind the oxalate in the gut so it doesn't get into the kidney. Right? So make sure your patient doesn't have too much calcium, but has a healthy dose of 1,000 milligrams a day. Citrate chelates calcium, magnesium inhibits crystal formation, and omega-3 lowers urinary calcium excretion. Finally, there's red sage and chickpeas, which have been shown clinically to reduce stone formation. And then we have bladder stones. They go along with malnutrition. So feed those babies nicely with a good diet, and the bladder stones will disappear. So that brings me to the summary. Good. There's a definite link between metabolic syndrome and stones. Antioxidants can reduce recurrent stone formation and protect the kidney. Vitamin B6 is helpful in hyperoxaluric patients, and so is the probiotic with Oxalobacter. No more low calcium diet for stone formers, but you might actually supplement to a healthy level the calcium. And citrate, magnesium, and omega-3 do reduce stone formation. So I hope this picture has been corrected slightly. We might go from this in urology to this, and finally to this. Thank you.